Service Manager here with Gosnells.
So I'm Taylor. Hello, nice to meet you. I'm the Program Coordinator here at Gosnells for the Family, Domestic and Sexual Violence Integration into Primary Care. Doesn't have a name yet, so it's quite long-winded.
The ways that we previously supported is through the programs that we have at the moment. So that's Young Hearts, our counselling program for children, CSAT, so the Child Sexual Abuse Therapy Service. FARS really isn't sort of a DV service as such, or domestic violence service, but they will still work with those issues. And then it's really around referring to partner agencies and using a case management approach to hold people who are experiencing that. So that's previously really how we've held it, and we try to utilise a place-based approach as much as possible to reduce those barriers, particularly when you're seeing, and it is predominantly women and children. It's a highly gendered issue, not saying that men don't experience this, but we really try to make sure that we're reducing the trauma load for people when they're accessing the different programs, but that's how we've held it previously. Sadly, there's really been an increase in family, domestic and sexual violence presentations, particularly in the last probably 2 years. And I think that probably comes on the back of a whole lot of different issues that we're experiencing within our society, but particularly in the southeast corridor. So I think that the way that this project will change things is it offers a more integrated approach to providing support for, again, people who are experiencing family, domestic or sexual violence. I think the other thing that it does is it increases the strengths of pathways within our community. And we're also really looking at upskilling or increasing the capacity of GP and other allied health staff within those settings to respond to the issues that they're seeing, because we know that it is a huge issue. And to give you, I guess, a little bit of a background around that, we have an existing informal partnership with the family safety team that sits just outside of Department of Communities. And what we learned was that the Southeast Corridor last year had the highest rates of family domestic violence incident reporting at a metro level, which is huge. So GPs also, I think, learning to recognise that it's really the model that we're looking at. And I'm going to hand over to you in a moment so that you can actually do some speaking, because I just feel like I'm just going blah, blah, blah. But
All good stuff.
All good stuff. But it looks at the 3 R's, which is really around GPs learning to recognise presentations of family, domestic and sexual violence, and then respond to that in a trauma-informed way, because quite often GPs don't know what to do when they're confronted with someone coming in and disclosing that. They might not even recognise it, because one of the primary issues too that we face is that there can be anomalous or unaccounted for injuries that women and children are presenting with. But unless GPs have that knowledge base to recognise what they're seeing, they may not necessarily ask the questions. And then the other part of the model, the last part of the model, is referring. So that's where this works, because it's integrating. It's integrating that space for providing like a, I think a fairly kind of wraparound response. And for GPs to feel connected. Do you want to add to that?
And some of the feedback from GPs is that they have been separated from the local service sector. So there's a lot of support within tertiary health around recognising and responding to family, domestic, sexual violence, but not in primary health. And they haven't been provided the skills or the knowledge or the education to be able to recognise and respond to family, domestic and sexual violence. The stat at the moment is that a single GP is seeing about 5 to 9 women a week that are experiencing family and domestic and sexual violence, but they're not skilled to be able to recognise and respond to that. And due to time constraints as well, there's that kind of barrier as well. What they've also fed back is that because they don't know the service sector, they don't want to ask the question because they don't know how to hold that space if someone does disclose and what to do with that. So I think what will be so key with this pilot is to bring that service sector integrated into primary healthcare so that they are able to kind of know what is out there to support their patients, to have that ongoing care alongside, I guess, the health, but the psychosocial aspect as well.
The strength of it brings to bear that specialist knowledge combined with also, I think, the fact that we can offer some place-based supports here at Anglicare. It really strengthens the response that we're able to provide. Plus, I think Starick also has a mobile outreach unit, which again kind of builds capacity and flexibility of service and meets people where they are.
Research shows that family domestic violence, when you've experienced for a long period of time, it is a chronic health condition. So it's how do we link the FDSV sector in with primary health to capture all domains of that person's life to support, I guess, positive health outcomes in the future as well. We have definitely had some referrals. There's one in particular where not engaged in any FDSV kind of support, hasn't ever previously, but felt that the GP was the only person that they could trust, and disclosed to the GP and wanted that support, and that's led to a referral and kind of ongoing case management support from an external agency. So that's the type of, I guess, patient or client that we want to capture that isn't linked in with the sector, to then build kind of safety and also build that GP's confidence to be able to ask that question and recognise what's going on, because that's going to have that lasting impact for them as well.
Definitely. And overwhelmingly what's been found in all the literature that's been reviewed is that GPs are, up aside from family and relatives, the first point of contact for disclosure. So being able to work within that space and build that relationship, we are seeing referrals that are coming through, which is fabulous. And these are, I guess, clients or women and children, because clients is such a weird word, but these are people that we might not necessarily have known about in the community. And then obviously having those referrals into our services as well means that we've got an opportunity to respond.
So we have Canning Vale Medical Centre, and then we have Thornley Square Medical Centre, Pramana Medical, Southern Star, and Spencer Road Family Practice. And I think the benefit of having this model here in WA, because it is a federal pilot, is that we have workers co-located, which means that we can really build relationships, and we know that's going to have sustainable change versus having someone on the end of a phone who's taking referrals, who's managing 100+ clinics. By having someone in the practice, we're able to look at those really minuscule things that we can do to create change and to create changes within like values and, I guess, attitudes towards family, domestic and sexual violence, which will hopefully create positive outcomes for the women and children in the area.
But the hope is, I think, in the second year that we really want to expand. And I guess, you know, there's a lot of learnings we're picking up along the way, and the context of each surgery is extremely important, and the context of the southeast area. We know that this is endemic. So this isn't just about being a social issue, it actually has massive health implications. So for GPs, I think in this space, it's a really good opportunity to, I think, recognise how family, domestic and sexual violence plays out on, I think, health outcomes, social outcomes, psychological outcomes, and and we can support you in that space. So it's not doing it alone, it's a partnership, and we're there to support that, because we really want to be able to see GPs feel supported in that space to support the clients that are coming through. And I think for clients who are accessing this service, I think it's also knowing there's a no wrong door approach. We are here, we'll take our time. It is a trauma-informed approach, so it's not just come in and there's an expectation to start telling your story. We'll work slowly And again, it's a partnership approach.
My goal is that if we can have someone come in and access a GP and they walk away having a positive experience and they felt listened and heard, that's a win, because that might not be an experience that they've had previously. So if we can support primary care to have that response and be trauma informed, that eventually down the line they might feel ready to tell their story, that's a positive. That's what I would hope, that they have that experience.